All right, starting hepatitis. First of all, hepatitis can be viral or not viral. We're not paying much attention to not viral hepatitis today, but as a recap, the main cause of non-viral hepatitis is alcohol. And other toxins. Another cause of hepatitis is obstruction of intrahepatic biliary ducts and tracts that causes stagnation of the bile inside of the liver tissue, parenchyma, and it's not auto-digestion in this case, but liver definitely suffers, and what we see is inflammation or hepatitis. Today, our discussion will be mostly about, or exclusively about viral heps. And here's the list of them. There's also Hep F. And I will stop briefly on some of them. But before I do that, actually, let's start with them. Hep A. A few things you need to know about this condition. It is acute. There is no such thing as chronic Hep A. Patients get sick, and then the disease goes away completely. It does not progress into the chronic condition. So patients recover fully or die. Yeah. One of my classmates in medical school had fulminant Hep A, and she died in the 4th year of medical school. She was 28.
Wow.
And she traveled with missionary somewhere to mid-Africa, ate something, and they flew her back with that type of life flight, intercontinental life flight. And we all donated everything to her that we could, money, blood, but within 12 hours she was gone. And it was not anything special, just happening. That bad. So who is at risk? Those who work with food. Those who specifically work with dairy food and shellfish. And I mean, those are people who grow it, people who water it, who wash it, who process it, who deliver it, who unpack it, and at all steps of that processing. What is the best way to prevent spread of this condition?
Wash your hands.
Wash your hands.
PPE.
No, it's ingested.
Oh, yep.
So do not eat raw fish if you're not sure that this fish is actually good. No chewing on raw lobsters. I know they're crunchy and chewy, but
I'm not a lobster fan.
No, I'm allergic to shellfish. So.
I'm allergic to shellfish.
Yeah.
You don't live in the wrong state.
Yes, sir.
all right, Hep B. Hep B. B stands for bodily fluids. So whatever you can think about bodily fluids and how they can be shared and transmitted, that's where you manipulate with causes of Hep B. So, blood transfusions, unprotected sex, using razors, toothbrushes, so saliva, dialysis, needle sticks, birth, open sores, wounds, all of that. So, open question, don't answer. You are witnessing car crash. the person is ejected out of the vehicle and is positioned very awkwardly somewhere on the side of the road. And you definitely see that there's pressure in the blood is like arterial bleed. What you gonna do? You're gonna, well, if it's arterial bleed and blood is squirting,
You're gonna compress it,
You're gonna cook it or something,
pressure on it.
but you're gonna use maybe.
Honestly, I would take a shirt or something to put pressure on it.
Do you mind if I'm
Yeah.
Try to
yeah,
just
but then you have a risk
Remove
to.
Oh,
And if you recently had
Thank
your nails done, you
Oh,
might
oh.
have micro cuts.
If you have a trash bag or
So,
anything
don't
that
answer.
don't protect your
Just
hands.
think in your head. Don't answer because I don't want anybody to be exposed to any judgments from either me or peers or imaginary. Think what you do if the person is literally bleeding out in front of you and you're not in the hospital, you don't have gloves. And you always assume that you can get, like, there's like a little boo-boo here. There is a risk to get it. But they're gonna die or you will save their life.
Oh geez, that's real dark.
So, yeah,
Yeah.
it is, but answer for yourself. Think, if you're prepared in your head mentally for this situation, you will be more active and efficient when it happens. God forbid it happens, but just FYI. Not get yourself like up to the elbows in blood. Think how to first be safe in the scene because it's the most important thing. At the same time, you gotta help.
I know a nurse that carries saran wrap in their car because of, you never know.
Some people carry, some people do not
I
carry.
don't know, I'm just saying.
I
And
still
now we
carry
wear gloves.
diapers in my car. I'm not sure what those are doing in my car, but
They are absorbent.
If you ever have an incontinence, you got it.
I got a
Yeah,
small
but they're
trauma
keeping
pack in my.
Well, you have
Like-
mine, you can use some liners.
anyway. So, C, Hep C. C stands for contaminated blood. Again, whatever you can think about contaminated blood and how it can be shared. Direct blood transfusion in the situations like military conflicts, when blood needs to be given or else. Needle sticks, dialysis, wounds, transplants, and so on. D and E, you just need to know that they exist. They exist. And F. Then, Hep A and B have vaccines. Hep C does not. We discussed that. How can a health, it's a real case. The nurse is, experienced nurse is teaching young nurses how to be safe on the floor and not get Hep. What is that we're doing? What are the interventions that nurse is suggesting?
Standard precautions.
Yeah.
Wash your hands,
Mhm.
PPE,
Mm-hmm.
vaccines,
Mm-hmm.
report anything that could have happened. Maybe you get a needle stick.
Mm-hmm. What are you going to do with your healthcare worker, like new hire, attempting to be a new hire, who got all Hep B vaccines, got a titer done, no titer, did another all vaccines, the whole thing, from the beginning, got a titer, no titer. What are you gonna do with them? Can they work?
Yes,
Yeah.
you had
Yeah.
to sign a waiver.
Yes, they need to work, they can work, they can sign the waiver, their body is not going to be immune regardless of how many attempts. That's myself, I had 3 sets throughout my life, I'm not immune to HEPA.
That's me too. I had to sign a waiver.
You just need to be more self-aware and attempt to protect yourself. Good morning. How do we prevent needle sticks? Select all that apply.
Safe tapping
Safe capping when you need to cap.
or use the safe.
Use the safety needle covering mechanisms, safety engagement things.
Dispose of the sharps container.
Use sharps container, do not put them in the trash, yep,
Make sure you're wearing gloves.
yep. Do not walk with a needle, or do not have open needle around other people. So if you fill up your syringe with a needle, with protonics, you must recap it and not walk with the open needle to the patients, but across the whole room with the visitors and family and maybe CNA. Okay. Symptoms. How will you know that one has HEP? Symptoms can be very vague. A person does not need to become bright yellow in order to have hepatitis. Yellow is when there's a problem with the bile outflow at some level of that outflow. HEP is not always having that. So a patient might have a dullness, dull pain, or feeling of discomfort in their liver area. They might have nausea, vomiting, diarrhea. They might have poor appetite. They might have fatigue. Or have no symptoms, or they may become icteric and jaundiced. But that is, if they become yellow, that means that the disease is more severe than the moderate level. Both Hep C and Hep B have a potential to go chronic. Labs, liver enzymes, and blood tests specific to HEP. Those are immunoglobulins. Depending what type of immunoglobulin you observe in a lab, increase, that means that the disease is in a certain stage. Other diagnostic assessments include liver biopsy and ultrasound. If the patient is either not compliant or poor tolerating their treatment, there's risk for weight loss and fatigue and poor energy condition. So we want to promote their nutrition. What kind of foods would you either recommend or not recommend to this patient?
Not high fatty foods.
Yes, no high fatty foods. How about some smoked salmon? Probably not. Careful with eggs and potatoes, because those stimulate bile outflow, and if there is a mild to moderate obstruction, which is not always due to the stones, it can be due to inflammation, because inflamed edematous tissue puts pressure on vessels that carry bile. And if some of those, especially the smallest, the narrowest ones, they're very easily collapsed by edema. So patient might have a problem there. Do people with Hep B and C stay in the hospital for the whole course of treatment?
No.
No.
No, they don't. They go home and continue treatment there. And they will be on like maintenance therapy throughout their life if they want to keep themselves in shape and kind of slow down the progression of their disease. They also need to know that their condition is shareable. And they need to be very careful about that. When I came to this country first, I lived in Westport, New York. I don't know, like Champlain, like Adirondacks area. And like maybe half a year into me being there, there was like big case in that whole Essex County. What's the name of the hospital? Champlain Valley Community Hospital. One of the local residents in the community discovered that they had HIV. And this person decided, got so mad and like went nuts about their condition and the future, and decided to contaminate every single person in Plattsburgh. So cut himself to the blood and got as much sperm as possible and was walking around Friday like doors in stores and like pharmacies everywhere, like literally where people would touch stuff. It was like in newspapers and on the radio, so everywhere. They got him. But liver transplant. What's that?
I had a guy do that in my psych ward with a MRSA bandage.
Oof.
Same reasons, then he went down to the gift shop.
There was a guy at Main Coast lived there for a long time that he would spit on people because he was
Positive?
yeah. One of the nurses got in their eye and had to be like checked.
Oh, well, with spit, just FYI, this happens to you. You need a bucket of saliva to contaminate somebody with HIV, yes.
But they still
Yeah,
made
but
it.
still, the concentration, even if you have 0.0001% of getting it, of course you will be tested.
Yeah.
But
Good to know.
it's not like one droplet of blood versus one bucket of saliva. All right. And one slide for liver transplant. It is reserved for patients with end-stage renal disease or acute renal failure when there's nothing to recover. You know, sometimes patient has acute liver failure or acute kidney failure, and you know that with certain treatments, some level of function or whole function will be restored. Like patient is on dialysis for a week or two, and then the organs recover. And the same liver sometimes does this too, but sometimes not. So for the cases when there is no future for the recovery, they do the liver transplant. Patient 4, and this you need to know, in order to get on the list and be considered, the providers who work with liver banks use MELD score. MELD score that considers labs and patients' clinical presentations. You do not need to know exactly what's there and how many points each finding gives you. It's not like Glasgow Coma Scale. That one you need to know by heart. This one, just know that MELD score is for liver transplant. Okay. Andrew is awake. Oh, my little baby. Oh.
Is she feeling better?
He feels better, yeah.
Your recording of your kids sleeping and talking was hilarious. During your recording, you're like, sorry, that's my kid, he's sleeping and he's talking in his sleep.
Oh. I tried to move him because his leg was like all over me. Sorry.
That's funny.
In real life,
Yeah.
so who can donate the liver?
Healthy individual.
Healthy individual. Or healthy from the point of liver individual. That person might have very sick heart. That person might be brain dead. We cannot say that they're healthy. They might have healthy liver. Make sure you word this correctly. So, patient with healthy liver. Can the person donate liver twice?
No.
Can I donate my liver twice?
I don't think so.
Certain lobes, right?
Once. In this country as a general idea. The reason is, yes, you all know that the liver has absolutely amazing abilities to self-restore and restore the function, but still, the function will be restored to the point when the patient will not need any supplemental therapy, but there will be still too much of connective tissue in that newly regrown area that it's not gonna be sufficient enough for anybody to receive it. So for us, donors, it will be okay. But for those who are desperate and have liver failure for a while and they have all metabolic changes already happened in the body, they'd rather get absolutely new intact liver than partially sclerotic one. You get the point. In other countries, that is considered because there is such a shortage. Here, liver is one of the least problematic organs to obtain, along with kidneys. It's like not like the heart or lung. Every single person after a liver transplant is on immunosuppressing therapy, so recall your teaching and interventions. If your immune system is suppressed, what is that you need to do or you cannot do or should not? Like when you go outside in public places, mask up, prevent any sicknesses, vaccinate, and so on. All right, this chapter is good. Let's talk about inflammatory intestinal disorders. I did not know you could choose the temperature on that pot. On the pot, the water pot.
Oh,
Can be, yeah,
Water.
special temperature. It just came to my mind that, oh my goodness, you can actually do that with that device. It looks rugged. All right. This is, I do not like this picture, and I will explain why. It gives you example of how Crohn's disease and ulcerative colitis look. So, for Crohn's disease, this is like from here all the way is colon. That little piece is a small intestine. That is appendix. Just looking at FYI in this picture, how do we listen to the patient's abdominal sounds? 1, 2, 3, 4. In the way how that pollen grows in the human body. So do not start up here. Starting here. 1, 2, 3, 4. So there's much more of small intestine than this. Crohn's disease affects small intestine anywhere and large intestine anywhere. Ulcerative colitis, this, affects anywhere from here all the way up to the end, including sigmoid and rectum, but never small intestine. So this picture is missing whole small intestine, And this picture does not show much of a colon. It's just a picture for the beginning of the chapter because we're starting with peritonitis. Peritonitis is inflammation of peritoneum. Peritoneal cavity is just like pleural cavity, just like pericardial cavity. It is a cavity, it's a space that is located between visceral and parietal layer of peritoneal, peritoneum is like pleura. So there are two layers, visceral and parietal. So if this is the stomach, that's the belly button. Outer lining, so this is liver. Outer lining is covered inside with parietal peritoneum. It's obviously underneath the skin, underneath the muscles, like fatty tissue, but inside. It lines up the walls. And if you have a gut here, I will put only like piece of it. Then on the top of the organ, it's going to be a visceral. So the cavity is not something of a perfect shape. It's just that space. Here it can be this much, here it can be this much, here it can be different. But that's the space that exists between the outside of the wall and all the organs that are covered with it. Not all organs are covered with it, by the way. Remember that kidneys are not within peritoneal cavity. The outside and the posterior. It's an NCLEX question. It is called retro. Retro word means behind, peritoneally. Then if patient has peritonitis, which organ is not going to be affected?
The kidneys.
Kidneys, because they're not within that cavity.
Okay.
So, inflammation of peritoneal, either parietal or visceral lining, or usually both, because when one gets inflamed, another one gets inflamed right away. What are the causes? It can be most times infection, but sometimes it's chemicals. Infection comes from the gut, and chemicals come from the gut. So both of those are kind of patient's own stuff. We are not sterile in our GI, but peritoneal cavity in males is sterile. In females, it is not, potentially. So when there is a perforation of the gut, and some of the content of the gut comes out in the peritoneal cavity, that content has some bacteria, and that bacteria causes peritonitis. Another thing, that within the gut we have some chemical substances. It can be gastric juice. It can be duodenal contents with bile and pancreatic enzymes. Those are very much chemically active, and they can cause peritonitis that is like chemical type. Obviously, most times you see combination because it's very rare to see just the leakage of the bile without leakage of the stuff from the gut. Unless it is a surgical mistake, like during the procedure, like cholecystectomy, the provider is trying to separate that gallbladder out and remove it and punctures it. And then there is leakage of the bile, but bile is at that point sterile. Complications of peritonitis include forming of adhesions, and do you remember what those are? Like connective tissue connections, extra connections, kind of reinforcements. Exudates and abscesses. Peritonitis is a life-threatening condition. It needs to be addressed right away. And I mentioned that. And I mentioned that. This piece of the statistics you need to know that peritonitis is a dominant cause of death from surgical infections. How will you recognize that the patient has peritonitis? Before all this, yes, that is valid and decent, it's a good information, but all this is too vague. You need to know one pure characteristics, one pure sign of peritonitis. It is called board-like abdomen. Board-like. And that's gonna be in quotation marks. Board-like abdomen. Because of like unconscious guarding, you ask the patient, hey, can you relax your tummy? They cannot. They will say, oh, I am relaxed. It's not relaxed. You cannot palpate anything. It's like 10 pack or 12 pack plus, and you cannot go in. Everything else is valid. Pain, tenderness, and so on. Let's take the example of the pain situation, because one of the conditions that we're gonna look at is appendicitis. And with appendicitis, pain very frequently starts in epigastrial area and then travels to right lower quadrant. And if there is a situation with peritonitis and appendix ruptured, the pain is going to be like a wave, like all over, and it may be not as intense in a while. Please remember that older adults are not prone to show significant levels of pain, especially if they have dementia. So if there is an older person that comes from skilled nursing facility or dementia unit, and they do not complain of pain, they just act like they're lethargic, and on your assessment, the only thing that you see is board-like abdomen. What is that they have? Peritonitis. Labs. White blood count, and you want to do it with differential, and you do expect to see increased white blood cells, increased neutrophils with the left shift. There might be some increased bands. How much bands is okay? Less than 5. Bands are immature neutrophils. Blood cultures always before the first dose of antibiotic, if possible. There was one occasion in Maine Coast Hospital when I could not follow this rule, and it was when the patient was absolutely impossibly hardest stick ever. The patient arrived with IV that was placed by AMS, and it was the only one, the worst IV ever, in a band that was beeping all the time, super positional. And in a smaller hospital, you have a phlebotomist, and that a phlebotomist could not get anything. And for blood cultures, you cannot draw from existing line. You must have a brand new access. So for a doctor, I communicated for a doctor, I started giving antibiotics because we could not delay. Before we got the cultures. In the morning, somebody else came and got the patient. But it was like 8 hours post first infection. All right, other labs are in front of you. The easiest way to see peritonitis is CAT scan. It's not X-ray ultrasound. Your diagnosis, acute pain, if you suspect that that is infectious, then infection, potential for fluid volume shift, and some other diagnoses that can include change in level of consciousness, risk for sepsis, right? Or risk for septic shock. So what are you going to give to the patient or do with the patient who has peritonitis? Your ideas. You are in ER and they come with peritonitis. Peanuts, yes.
But ones that don't metabolize in the liver.
Okay.
Would you give them
Drop
like heat,
one.
like a heating pad? Would that help at all with pain? Like a no.
They have, in most cases, infection that is all over their tummy because of the most likely hole somewhere in the GI tract. What you gonna do?
Drop blood and then give them the antibiotics.
Yes.
NG tube?
Yeah.
Baby fluids.
Mm-hmm.
I mean, we gotta prepare for surgery, right?
Mm-hmm. Or at least surgical consult. And the procedure that they're going to do is exploratory lab. It's not gonna be with those laparoscopic sticks. It's gonna be exploratory means they're gonna explore. They need to have good access. All right, appendicitis. This picture shows you a perfect spot where the patient has most of their symptoms in the case of appendicitis. It's called McBurney's point. The type of tenderness is called rebound tenderness. When you hear rebound or read rebound tenderness, you should associate it with acute appendicitis. In the nursing world, that's what it is. The pain may radiate in the upper leg, like upper right leg.
Go for it now.
So, what is appendicitis? It's acute inflammation of appendix that is located in the right lower quadrant. So, let me go back into the picture, first picture here. This little thing can be obstructed with, or filled with pretty much whatever comes through the small intestine. It can be a pit of a cherry, it can be chewing gum, it can be a sunflower seed that you just swallowed and you did not chew it. It can be a corn that you again swallowed and did not chew on it. Or even if you did everything correctly and chew and process absolutely gorgeously, it can be random stuff, just a piece of a food. And there's inflammation here in this little area. The wall of the gut is very thin and it's very easily rupturable. If there's a hole in the wall, the contents come out, and it may cause peritonitis. Another way of how this can go, the abscess may form here. And if abscess is small, there's appendicitis, but there's a small abscess. That can be treated with IV antibiotics, or if abscess is somewhat larger, that is like interventional radiology. If that is peritonitis level of a concern, then it is exploratory lab. By the way, in some people, appendix looks like this. In about 20% people, appendix is a random structure. And it can be as long as here, and there's liver right here. It can be long and sitting underneath the liver. Like this long. I know. That's probably the longest that I've seen.
What did they do with it? Did they leave it in them?
Oh well, that one that I observed was in a cadaver.
Oh.
Oh.
Ooh. Ooh.
Anything else interesting in that cadaver?
Is it, I processed more than 100.
Oh, wow.
I cannot make connection. I don't remember. So what are we doing with these people? Oh, well, who have appendicitis? For non-surgical management, we want to keep them in NPO. So how do we keep NPO? Nothing for mouth at all, or can they have ice chips?
I've seen people give ice chips.
Yes, or at least a ice chip,
Yeah, like
or the
Martell.
ice chip.
Yeah.
Yeah, they might, the provider may put an order for the NG2 placement. Pain management, antibiotics. Surgical management, appendectomy. If it is indicated, more and more frequently you see non-surgical management of this condition. The provider will assign a course of IV antibiotics and will ask to do new CT scan in like 3 days maybe. And if there is no improvement, then yes, surgery. Next condition, gastroenteritis. This is a condition that is most times viral. Sometimes bacterial, but mostly viral. Usually the symptoms go away within like up to 3 days. And those symptoms, most of them are vomiting and diarrhea. And now think about nursing diagnosis here.
Electrolyte imbalance, fluid imbalance.
Dehydration.
Very good. And if you're dealing with a child who is vomiting and diarrhea for 3 days,
Uh-oh.
yes, then your hair should start moving in your head. So their most dangerous risk is dehydration. And you remember the signs of dehydration in younger kids, especially those who still have their fun. Yep. Perfect. So besides kids, older adults at risk too, because they have, first they vomit, second they have less fluid in their body to begin with, third they have decreased thirst mechanism, so they did not feel thirsty when they should. Okay, Denise.
I saw that.
I just got it.
Yeah, it just came through.
What is it?
Denise.
Saying when we following baby poses and boys on kids.
A little late. Class starts an hour ago.
It's nonverbal communication. I mean, I agree, we kind of screwed up. All right, at least we'll have a chance to cover all of this.
Yes.
Okay, so if you have an elderly, if you have a child, if you have somebody who is immunosuppressed, if you have somebody who has problem communicating, like patient with dementia, or patient with who are mute, or patient who have developmental delay, patient with autism spectrum disorder, those are within our big concern list. FYI, select all of the Y. Those who cannot relate their problem, or who will say, I'm just fine. So, main intervention, how to prevent this infection and this condition, is hand washing. On assessment, you ask if the patient had any recent travels. And please do not think that this is a travel to the opposite side of the world. It can be travel to Olive Garden. Yeah, if somebody there did not wash their hands, or you did not wash your hands. Then you want to ask what the patient was eating and where. Then you want to encourage fluid replacement and oral rehydration. Please, the key word here is oral. If the patient is able to tolerate PO intake, we want them to do that PO intake. We want them to drink. It's always better to rehydrate a human through their natural route, already existing mouth. What if the patient says, you know what, every time I jug a glass of water, I vomit?
Small steps.
Small sips. Do not take the whole glass at a time. Colder drinks that are not carbonated, and sit upright. A little bit before, during, and half an hour after. Everything that I mentioned is your teaching and intervention. FYI. And sometimes antibiotics needed if that is not a viral. If that is a viral, no antibiotics.
Does it resolve on its own? Or
Yeah.
can it?
If it's viral, yes.
Okay.
We just need to provide supportive therapy. Ulcerative colitis. You will not see this picture in your exams because it's quite non-specific. But it is how mucosa changes. It has ulcers, like this is ulcer, and it's bleeding. This ulcer bleeding. And it is in the colon, and one of the preferred location for this condition is descending colon, sigmoid and rectum. So very close to the end. And because of those bleedings that are close to the end, what is that the patient might have in their stool? Blood. And it's not gonna be melena, it's not a black blood. It's fresh red blood. There is a special way to describe that poop, and you will see it in NCLEX and anywhere you see ulcerative colitis. It's called raspberry jelly.
Okay.
Imagine the color, any red jelly. Mucousy blood. And it's not just patient sits on the toilet and there's a puddle of blood. It's poop with that blood. This is autoimmune condition. Let's mention that. And other factors, we do not know obviously everything about it. Other factors like genetics, presence of other autoimmune conditions, environment, patient's diet contribute to this. It comes with remissions and exacerbations. And the treatment, hold on, no, not the treatment. The onset of this condition is in young age group. When you do assessment, you will notice a few non-specific changes, such as low-grade fever, poor energy, poor appetite. Patient may complain of, if they are in exacerbation, in abdominal pain and bloody poops. What you gonna assess them in the lab? H&H, because they're bleeding out. Increased white blood count. C-reactive protein and erythrocyte sedimentary rate. And low sodium, potassium, and chloride. Also low albumins.
You're popular this morning.
It's Denise. I'm popular with Denise. Okay. I appreciate the speed of the response. It's nice when she reacts so fast. Other diagnostic assessment: MRI, upper endoscopy, and colonoscopy. Colonoscopy is the gold standard. Why would we want to do upper endoscopy? Your ideas?
Make sure there's no bleed on the top.
Very close.
Erosion.
Very close. In order to say this is like pure ulcerative colitis, you need to make sure that there are no lesions of this ulcer kind anywhere else but in colon. So that's why they're doing endoscopy, to check what's in the small intestine. If small intestine is nice intact, and the problem is in the colon, that's colitis. Colon colitis. Your nursing diagnosis: diarrhea, acute persistent pain, and potential for lower GI bleed. What kind of ABG abnormality will this patient experience with diarrhea?
Metabolic acidosis?
Yes, because they're gonna be losing base.
I wish I would have got that right on the midterm.
I don't know who got what, but yes, that is correct. Anytime you see diarrhea, you think loss of bile and base cell stasis. Very good. What kind of pain medication do you think this patient will require? A lot of. And last slide about ulcerative colitis. Like few key points, and after that, let's take a break. Patients with ulcerative colitis are sentenced for life. That's a chronic diagnosis. Many of them receive colostomy. They end up having colostomy. What kind of stool will you expect to see from ascending colon, more liquid. What kind of stool you expect to see from sigmoid stoma?
Forms.
Form. Perfect. So, thinking of that, what would be your teaching to the patient who has ascending colon stoma? If they are losing liquid stool, most of their colon did not have a chance to work and reabsorb water and electrolytes. What you gonna teach them?
Hydrate often.
Hydrate.
Good electrolytes. Like
Yes,
make sure you're-
eat and drink your electrolytes. Absolutely. Because you remember that small intestine, main function, if you need to remember one, is to absorb nutrients, and large intestine is there to absorb water and electrolytes. So if the stoma happens early in the colon, then the output comes out before it gets reabsorbed. So we need to pay attention to patient's hydration status and the electrolytes.